Hello, good afternoon, and welcome to the Health and Government Operations Committee. Today we have 8 bills and 40 witnesses. We have the usual committee rules. The presenter will have 5 minutes to present the bill. They can save any of their leftover time for their supporting panel. Witnesses will each have 2 minutes, whether they're proponents or opponents. We have the committee rule of 1 question and 1 answer from the panel, of course. The committee is going to be taking a break probably around 3:30. We'll shoot for as close to 3:30 as possible for 15 minutes so members can stretch, use the restroom, etc. With that, I'll give you the bill order for today. We're going to start with 636, House Bill 636, then House Bill 544, House Bill 912, 709, 675, 731, 970, and ending with House Bill 216. So again, that's 8 bills and 40 witnesses today. And we will start with Delegate Belcastro's bill, House Bill 636, Maryland Healthcare Commission Assisted Living Programs Study. Delegate Belcastro.
Thank you, Chair Kelly, Chair Pendergrass, Vice Chair Pena-Melnick, members of the Health and Government Operations Committee. Thank you for the opportunity to present House Bill 636, Maryland Healthcare Commission Assisted Living Programs Study. This bill is the result of hard work by the Oversight Committee for Quality of Care in Nursing Homes and Assisted Living Facilities, which I serve on along with our friend Delegate Kerr, and also the bill's cross-file, Senator Bidle. In Maryland, there are roughly 1,700 assisted living facilities, and of those, 1,285 are 9 beds or fewer and care for 7,035 residents. And that makes up about 28% of the overall assisted living population in the state. And since joining the Oversight Committee 2 years ago, I couldn't help but notice a common trend and continual mention of our smaller assisted living facilities. And through the work of the committee, it became really apparent that our current model of regulation for these facilities, it needs a closer look. Currently in Maryland, whether the facility is a small home in a residential neighborhood or a large apartment style building with 100 beds, we regulate them the same. And we recognize that there are many differences associated with running a small facility versus a large facility. And that's why we believe it's important that we take a closer look and study the industry so we can better understand and identify pathways to increase quality of care. So under this bill, the Maryland Healthcare Commission would be required to conduct a study regarding the quality of care provided by assisted living programs with 9 or fewer beds. And in the study, MHCC would analyze OHCQ inspection data, consider a reporting system for data related to catastrophic health emergencies, determine whether programs with 9 or fewer beds should be regulated differently, and determine whether assisted living programs receive sufficient reimbursement for their services provided. So the study under this bill would have to be completed by October 1st, 2023. The findings and recommendations would be submitted to the governor, MDH, and the General Assembly. And again, we believe that this would provide us pathways to elevate that standard of care in our smaller assisted living facilities. So I want to thank you again for the opportunity to present House Bill 636, and we ask for your favorable report. Thank you so much.
Thank you so much, Delegate Belcastro. We have 3 folks signed up in support. Let's hear from Tammy Bresnahan.
Hi, good afternoon, Madam Chair and members of the Health and Government Operations Committee. My name is Tammy Bresnahan. I am the Director of Advocacy for ARP Maryland. It's nice to see you all. We are in support of House Bill 636 with Delegate Castro champion this issue, and Delegate Kerr and all the other folks that serve with us on the Long-Term Care Oversight Committee. That's where this issue has arisen. AARP is a mandated participant in that committee. What we are all familiar with is that assisted living facilities usually provide residents with their own apartments or rooms, as well as some common areas. The smaller ones it's often see them, they'll be sharing a room, sharing common areas, in contrast to, and providing level 3 care as well. In contrast to nursing homes they have no federal quality standards exist for those assisted livings. Additionally, states vary significantly in their licensing requirements, and we have been working with the Office of Healthcare Quality to address those issues. As a group who is represented on the committee, it has been brought to our attention by the committee that problems in smaller assisted living, such as inadequately trained staff, too few staff, medication errors, and the admission and retention of individuals is in need of addressing. And that's what we believe that this study will do. Again, we applaud Delegate Belcastro and the other members that have been on the committee working on this issue and ask you for a favorable report of House Bill 636. Thank you.
Thank you. Next, we have Eric Cultromero.
Thank you, Chair Kelly, and thank you, Chair Pendergast and Vice Chair Peñamela. For the record, Eric Cultromero, Director of Government Affairs for the Alzheimer's Association in Maryland. I want to first start by thanking the bill sponsor, Delegate Belcastro, for her leadership on issues related to long-term care. Last session, this committee passed legislation which requires an update to Maryland's assisted living facility regulations. I am pleased to say the Health Department is implementing that law, and I hope that regulations are promulgated by the December 2022 codified deadline. Delegate Belcastro and Tammy have mentioned the framework of the law. I just want to emphasize a couple of key points within my testimony that's in front of you. First and foremost, these small assisted living facilities are important. They are also structured differently than larger providers. They're not required to have an industrial kitchen. They're often at someone's home. Residents may share beds, and the onus is on caregivers who are within them, the staff within them, in a way that larger providers simply do not have. We're asking the Maryland Healthcare Commission then, in turn, to look deeply at these small providers, examine the quality of care and the Health Department inspection data, consider why, as Maryland has averaged over 130 closures of assisted living facilities, what role these small providers have and how we can ensure their stability. And then, as Delegate Belcastro mentioned, look forward to the next public health emergency and consider how we can have quality of care data readily available about them. These providers are important. They provide care to residents, especially those who are in low income situations. And I'm pleased that AARP and Lifespan are in support of this legislation. I urge a favorable report.
Thank you so much. We do have Dana Kaufman signed up. I don't think she has signed onto the Zoom yet. Giving you a second, Dana, just in case you're here. Otherwise, she has also signed up in support, and I will note for the members, there's a lot of written support in the file, but no opposition. Do we have questions for the panel from the members? Delegate Saab.
Thank you, Madam Chairman. And I know, Eric, you just mentioned something about, my question initially was going to be before you actually testified, like why is it 9 beds or less? But how do we handle the larger facilities? I know that this study is specifically for long-term facilities for 9 beds or less. So how do we handle the larger providers? I know it's not in the bill, but I guess my question initially was why weren't they included? So if you can just touch on that, I would appreciate it.
Delegate Saab, I saw that you mentioned Eric's name. Would you like me to answer it, or would you like Eric to answer that?
Anyone that's able to answer is fine.
So in this bill, we are just addressing the 9 beds or fewer. In my testimony, I mentioned how since joining the Oversight Committee, this is a continual issue that comes up, the 9 beds or fewer. We keep talking about issues related to data, lack of information on our small assisted living facilities, and also struggles with OHCQ being able to get around and do their quality of care checks in these smaller assisted living facilities. So I understand and share in some of the concerns that you or maybe your constituents have for the larger facilities, but we are just addressing the 9 beds or fewer, and we think that it's important that we keep it that way in this study.
Thank you. Thank you, Madam Chairman.
Absolutely. Delegate Hill.
Thank you, Madam Chair. Thank you, Delegate Belcastro, for this legislation. It's really important. So the question has to do with MHS, Maryland Healthcare Commission, saying that they think this is an important study. They even suggest some things that could be added. And they say they don't have the staffing to do the study at this time.
Thank you for raising. Sorry, I don't want to cut you off.
You got it. Go.
I want to thank you for raising it. I was shocked yesterday when I logged in to see the testimony, because we met with MHCC about a month ago, and we told them all about this study, what we were planning to do, and they were on board. Now, I know this committee is well aware of issues with funding at MHCC. What I will say is we have another wonderful delegate on our committee that has a bill that will help increase funding at MHCC should it pass this year. So, we believe that will help, but also we were just surprised because we thought we had all the stakeholders on board based on the meetings that we had with MHCC.
Thank you.
Yep, thank you for the question.
Any more questions from the committee for this panel? Okay, wonderful. Well, that concludes the hearing on House Bill 636, and we will move on to House Bill 544, which is Delegate Chi, Health Facilities Residential Service Agencies Reporting Requirement. Delegate Chi, welcome.
Thank you, Madam Chair, and good afternoon, members of the HGO Committee. Very glad to be back. I am Delegate Lily Chi here to present HB 544, Health Facilities Residential Agencies Reporting Requirement. This is a simple bill that requires Medicaid-funded home care providers, also known as residential service agencies or RSAs, to annually report to the Maryland Department of Health the wage rate and the classification of their workers. I'm offering a sponsor amendment that would strike out the rest of the bill, which is number 3 to 5 on page 2, to make the bill even shorter, essentially, related to collecting data on benefits, and also making sure that MDH will annually report on the data they collected, and that it would only report such data in an aggregate fashion, so that we would remove any concerns by RSAs of potential data sharing with competitors. This committee heard and passed a similar bill last year that initially included this reporting requirement, but it was removed as a compromise. And instead, the bill passed last year simply required the Attorney General's office, in partnership with the Maryland Department of Health, to produce a guiding document to the RSAs who will certify that they have read and understood the expectations regarding employment laws. So why are we adding back this requirement of wage rate and classification? There are several compelling reasons. First, it is a smart thing to do. Since Maryland is paying 60% of the cost of home care for those RSAs that receive Medicaid dollars, we should know how the money is spent. Better data collection helps the state understand the extremely high turnover rate and the dire shortage of this labor force. Problems that are exacerbated by our rapidly aging senior population and the pandemic that increased the demand for home care. Second, it is a necessary thing to do to secure federal dollars coming our way. Within the next few months, the Congress is expected to pass a reconciliation bill that approximately would give $150 billion for states to fund home care programs. The condition is that for states to receive the funding, we have to, and Maryland, by the way, is expected to gain over $1 billion out of that total amount. We must provide the federal government with up-to-date data on workers' wages and benefits, which Maryland is not currently collecting. With better data, we can leverage and unlock federal dollars to hopefully increase our state's reimbursement rates for the RSAs that have to make their payroll and stay afloat. Finally, it's the right thing to do. Home care workers are over 90% women and 70% Black. Low wages and the lack of basic benefits like a workers' compensation in jobs that are very prone to high injury rates because of lifting, for example, have not only led to a large class of working poor, but also hurt the populations they care for and the industries that employ and train them. I want to thank the hard work of this committee in passing last year's bill as an important first step in the right direction without being heavy-handed with the RSAs. And I also appreciate very much Delegate Ariana Kelly's leadership and for her co-sponsorship of this year's bill. And by the way, this year's bill also received the tremendous support from many organizations, including some home care companies in that industry, because a fair marketplace benefits everyone, including businesses. I hope this committee will return a favorable report on this common sense bill that will be a win-win for the workers, for the RSAs to leverage better federal funding, and for the Marylanders who rely on home care services. Thank you.
Thank you, Delegate Chi. I'm receiving a message that you have 3 folks signed up in support, David Rodwin, Stephanie Williams, and Tammy Bresnahan. But right now, the only person we have is Tammy Bresnahan. So we'll hear from her, and I don't know if maybe the others are in a Senate hearing or there's something.
Yes, the Senate is almost simultaneously having this hearing, so they might be stuck just a few minutes. Thank you.
Also,
Okay,
if
so
I may, I just want to
Yes.
say that we do have David Rodwin here available.
Oh, David is here. Wonderful. Let's hear from David, and then we'll hear from Tammy. David, go ahead.
Thank you, and apologies. We're indeed scrambling to get back from the Senate hearing on this bill, which just happened a moment ago. Good afternoon, Madam Chair, members of the committee. My name is David Rodwin. I'm an attorney at the Public Justice Center, where I focus on issues faced by Maryland's home care workers. I'd like to thank Delegate Chi for introducing this important bill. As an initial matter, just for clarity's sake, I don't think anyone was planning on introducing this bill this year until the federal government started talking about there being $150 billion available to states just for Medicaid funded home care, but only if states can report to the federal government information on workers' wages, workers' benefits, turnover of these workers, and vacancy. The Maryland Department of Health already has the information it needs to do turnover and vacancy, but it does not have information on workers' wages and benefits. Folks who know more about this than I do expect that a reconciliation bill is going to pass. And one thing that all of the folks whose votes matter on this one agree on is the necessity of these funds. There's no disagreement on it, and it's been in every draft of the bill. And I also would like to thank members of the committee, in particular, Chair Kelly, who really sort of helped broker a very difficult process in subcommittee. A lot of members put in a lot of work on the bill last year, but this is really about trying to access these new federal funds that everyone expects will soon be available. I just want to also note that with the sponsor amendments, reduces the already low burden on agencies and ensures that all of the information they produce will be kept confidential, and that the Maryland Department of Health will produce a report with the information, but only with non-individualized sort of aggregated data. So folks don't need to worry about their data getting out there. So with that, we just ask for a favorable report. Thank you very much. Oh, and Stephanie Williams is here with me. She's a worker, a home care worker. If it's all right, we could just use my Zoom if that's okay.
Absolutely. We'll call her next and she'll have 2 minutes. Stephanie Williams.
I'm sorry. I don't know if there were any questions or if you're waiting for.
We'll do it. We'll do Stephanie first, and then we'll hear from Tammy Bresnahan, and then we'll go to questions.
Okay.
Stephanie, go ahead.
Good afternoon.
Good afternoon.
Good afternoon.
Good afternoon. You may start your testimony whenever you're ready.
Go ahead.
Yeah.
It's okay. Just go ahead. Go ahead. Just introduce yourself.
My name is Stephanie, and I'm a healthcare provider. And I agree with this bill because I still make $11.75 an hour, and I work 35 hours a week with no benefits. And the state should know that.
Hey, Jeanette, can you come here?
We're considered as being independent contractors instead of employees.
Hello.
Delegate Parrott, if you could mute yourself, we're hearing very important testimony. Thank you. I'm so sorry for the interruption, Ms. Williams.
Yes. I receive no benefits. I work with my client has a disability, and I also believe that more money is in play for the agency instead of the employees. And we're still losing people that love to do what they do, but because we don't make no money, they're going to work for Royal Farms and McDonald's at $15 an hour with benefits. Thank you very much.
You very much for your testimony. We really appreciate it. Let's hear from Tammy Bresnahan, and then we will open it up to questions. Tammy, are you here?
Yes, I am here. Thank you, Delegate Kelly. Can you turn your mute? We're kind of juggling a same area because we were all in the hearings. You turn it all the way down. I just want to say that I'm in support of House Bill, 544. We really thank Delegate Chief for championing this issue for the last couple of years. You know, Maryland is aging, and I guess just the mere fact that I'm with AARP just reminds people that we are aging. Maryland, according to the Maryland Department of Aging, has more people over the age of 65 than we have children in public school. That's a statistic that is staggering. We know that in the future, we're going to need professional healthcare workers to take care of this older population. This group is very, very important to the healthcare spectrum. And we have a fiduciary responsibilities, not only as policymakers, but as taxpayers. We have Medicaid dollars who fund these programs. And we should want to know, or at least the policymakers should want to know, how those dollars are being spent. As you heard from one of the workers, it is just unusual that, you know, these people are caring for the elderly, they're caring for the sick, but they don't have any benefits. They're considered self-employed contractors, which creates a whole nother issue. And if they become sick, then they wind up on our Medicaid rolls as well. And so I'm asking you to give a favorable report to House Bill 544. We thank you for your attention to this very important issue. Thank you.
Thank you very much. That concludes the panel of proponents. Do we have questions from the committee? I know Delegate Chisholm had his hand up, but I think it is down now, but Delegate Cullison has a question. Delegate Cullison.
Thank you very much, Madam Chair. I think I'm going to direct this to Mr. Rodwin. So my understanding is that this bill clarifies that the report is annual, which was not in last year's bill. So that I understand. But I'm worried because what I heard you say is that the federal money requires the report on benefits as well. But I'm hearing that the amendments take benefits out. So can you help me understand how, are we still going to be eligible for those federal passbacks if we take that benefit piece out?
Yes, thank you, Delegate. So as drafted and introduced, the bill, it provided for reporting on wages, whether the worker, in other words, wage rate, whether the worker was an employee or independent contractor, and then several sort of other specific benefits like workers' compensation, coverage by the Healthy Working Families Act, Maryland's sick and safe leave law, and whether the home care agency was providing health insurance. Through some conversations with the business community who felt that it was too much, and also with just sort of our own understanding, we know that folks who are employees will receive, people who are classified as employees will receive workers' comp protection, will receive coverage by the Healthy Working Families Act, and assuming that the RSA employs at least 50 people, and most do, they'll receive health care through their business. So the feeling was it was a little duplicative, given that you already know whether the worker receives benefits, if the worker is being classified as an employee, and the worker is not receiving benefits at all of any sort, if they're being classified as an independent contractor. So it's sort of a shortcut to all the information that Maryland would need to know.
And the bill does require that we show which are employees and which are independent contractors.
Yes, exactly right.
Okay. Thank you, Madam Chair.
Absolutely. Delegate Cullison, I allowed you a follow-up, but I'm going to remind you about my pep talk at the beginning. We're going to limit follow-ups till absolutely necessary. Otherwise, we'll take them offline. Delegate Chisholm. I think you're on mute, Delegate Chisholm.
Thank you, Madam Chair. So I'm trying to ascertain what type, so you're going to get all of this information. Is it going to give information on who exactly the independent contractors are, meaning Joe Smith makes $12 an hour, or is it going to be a summary of they have 10 employees that average $17 an hour?
Thank you, Delegate. That was another concern raised by folks in the business community, and the sponsor amendment addresses that by being crystal clear that all of the data produced cannot be released except in the aggregate. No individualized information can be released. So the Department of Health is going to go right to the Department of Health, and then the Department of Health is specifically prohibited from releasing any individualized information about workers or residential service agencies. And the Department of Health will then need to use that information to do an annual report on reimbursement rates, which I think there's agreement between the business community and the broad coalition of stakeholders here that reimbursement rates are too low. They're right now $20.54 an hour. We agree that's too low. So the report's going to be on reimbursement rates, on costs that RSAs have, as well as on wages and benefits. So a sort of report that'll inform you all and other policymakers so that we can get to work solving this really devastating home care workforce shortage.
Thank you, Madam Chair. I'll save the rest of my questions for subcommittee.
You much appreciated. Delegate Krebs.
Thank you. I was looking at the fiscal note and it said that there was not a prior introduction yet. Yeah, we did have a bill last year. I was reminded, a House Bill 652, and it reminded me we carefully negotiated that, and everyone was happy with it. But it's my understanding that the information that this guidance document that's going to come out has not even been rolled out yet. So given the fact that we negotiated this last year and it's just being rolled out, what would this bill do that the rollout of what we negotiated last year? I still don't understand exactly what this will do in addition to what we agreed to last year and why it's necessary before it's been rolled out. And that could be for the sponsor or whoever wants to answer it.
Thank you. I'll take a stab at this first. Thank you for the great question. So last year's bill, as this committee amended, it simply asked the AG's office in partnership with the Maryland Department of Health to produce a guidance document in simplified, very simple, straightforward English to explain to the RSAs what the employment laws are and how to make sure they are in compliance, how to classify workers properly, whether they are employees or contractors. And the RSAs are just expected to sign off and say, we read it, understood. Every 3 years, they will recertify to make sure they are on board. That was it, basically. We removed any requirements by this committee. So this year's bill, out of necessity, we have to add it back because there's federal dollars on the table we want to leverage. And the condition of unlocking the federal dollars is we provide up-to-date data on wage rate and benefits. That's it, basically. And by the way, the AG's office has already produced the document, but the Department of Health has not distributed, but we hope they will distribute very soon.
We have a question from Delegate Shalega, followed by Delegate Saab. Delegate Shalega.
Thank you. I thought I saw Dana Kaufman on.
Yes, she'll be testifying next in the unfavorable
then
panel.
I'll just wait. Thank you.
Delegate Saab.
Thank you, Madam Chairman. So I'm just trying to understand the bill a little bit more. So I understand it's a reporting bill. And then the information that we get from this bill, we're going to determine whether the reimbursement is low or high, or it needs to go higher. How do we ensure that this money actually end up in the pockets of the workers? Because this is only deals with the reimbursement. So, and I'm just looking for the future and if this bill addresses that in there. Thank you. Anyone can answer the question. David, maybe you want to answer that.
Sure. Thank you, Delegate. If it's okay. So you're correct that the bill doesn't say specifically what policy changes would be appropriate to use to fix the problem. This bill is really about a sort of data gathering and less about prescribing specific solutions. And then, as Delegate Chi mentioned, it's of course also about just doing what we need to do so that we can get Maryland this money and increase rates for home care agencies, which will increase pay to workers. There are several more specific models to ensure that more of the money reaches workers. There's a model called a wage pass-through that many states have done, about half of them, which simultaneously increases reimbursement rates while requiring that some dollar amount of that increase has to be passed through to workers. There's another model that Maine just passed that is sort of similar. It basically says you have to increase reimbursement rates, and then workers need to be paid at least 25% more than minimum wage. But there's a number of different models to do that, to make sure that workers are getting enough so that we have a healthy and adequately sizable workforce. But sort of this bill is more about informing those policy discussions rather than prescribing what they might be.
Okay, thank you. And the reason I bring this up, because I think it plays from both sides, from the business owner side, where some of them are already paying higher wages anyway, because that's what the market and the demand, but some of them are even losing money in some instances or making very little on the spread. So I wasn't sure. So I appreciate it. Thank you.
Delegate Hill.
Thank you, Madam Chair, and thank you, Delegate Chief, for bringing this forward. I just want to clarify this to make sure. I know some of the original goals because I carried this legislation a while back. And last year's bill was a carrot for employers to try and do better by informing them. This, again, is not allowing for any targeting of an employer because everything is aggregated. So it's not really getting at the issue of whether employees are misclassified, correct? It is just giving a report so that we can comply with the federal regulations so that the money can come in. And we're not able to look at any particular employee to say, you called that person a contracted employee when they really should have been. We're just hoping that with education, they'll do better. So it's not a backdoor way of getting after misclassification. It's just trying to do better for the employees through the program. Is that correct?
You are correct, Delegate, and thank you for your leadership on this. You were the original sponsor that came to my committee. Thank you. Yes, you're correct.
Thank you.
That looks like all the questions we have for this panel. I do see Dana Kaufman here, so I'll go ahead and call her up and she can give her testimony for 2 minutes. Dana?
Thank you, Chair Kelly, members of the committee. I had to laugh because you said call her up and I'm still sitting in my seat. But for the record, I'm Dana Kaufman. I'm here today on behalf of Maryland National Capital Home Care Association. We are opposed to this bill. We did think it was premature when we saw it. We do appreciate Mr. Rodwin bringing it to our attention before it was introduced. But just to clarify, for last year's bill, it did 2 things. So the first is the guidance document that has to basically, it's 3 pages, give an overview of the differences between employees and independent contractors. And then there has to be an attestation by the individual who's in charge of payroll to ensure that the agency is in compliance with all state and labor laws, including the distinction between the 2 classes. The second part, which was done in lieu of this bill requiring pay rates, was that on a form created by the health department, there has to be a checkbox that the agency uses independent contractors. I have been in contact with both the AG and the Maryland Department of Health. Both are supposed to be rolled out within the next couple of weeks. So to us, that was what we did in lieu of really what this bill is doing. Second issue I want to raise is there is a greater issue here, and that is the Medicaid funding issue. And we don't need this bill to tell us that the Medicaid funding is inadequate for residential service agencies who take Medicaid. Back in 2018, because of a report that this committee requested, we already had the information and they were able to do a very detailed report that showed the differences between cost of care and reimbursement. That report needs to be updated because of the increased costs associated with COVID-19, but you don't need this bill because we already did it once and we can do it again. So I just wanted to make that point. The last point deals with the federal legislation that is the Build Back Better. I am not an expert on federal legislation, especially this one, but it has had issues in Congress. And I think before we would pass a bill based on a concern that we might be leaving money on the table, I think we need to better understand really what the requirements and what this federal legislation may require of states and the timing of that, because next year you will have the information of whether or not agencies use independent contractors. So again, I just want to caution with the federal legislation.
I'm going to wrap you up because you're out of time.
I'm out of time.
With a question. Do you have any cautions for us about the federal legislative timeline?
Oh, thank you. So I just think we need to take a closer look at that. if there is a concern that we're leaving money on the tables, because, and again, I'm not an expert, but I think it would behoove us, because it was my understanding that states can apply for a grant. And then in doing that, there are certain steps that have to be taken. So I don't know if it's really right off the top, leaving money on the table, but I think we need to take a look at it because I don't want to misspeak.
Thank you very much for that. Any other questions from members of the committee for Ms. Kaufman? Delegate Shalega.
Thanks, Dana. The question for you. So I think it would be safe to say you feel like this bill would preempt some hypothesis of what Build Back Better may or may not pass, may or may not want, and that what we did last year is the direction we should go.
Yes, I think that we worked hard to get that legislation where it was, and it's on the eve of being implemented, and we think it should be allowed to be implemented before we start making changes.
All right, thank you.
Delegate Chisholm.
Thank you, Madam Chair. Dana, do you know what the total dollar amount we get annually from the federal government to go to RSAs?
Well, so RSAs is a Medicaid program, so it's a 50-50 match. I do not know the amount of state dollars that is put into the Medicaid program. So it would be 50% feds, 50% Medicaid. I mean, I'm sorry, 50% state.
I understand the percentage. I didn't know if you knew the total dollar amount.
No, I don't. We can, we can basically ask the health department and get back to you on that.
Thank you very much. Thank you, Madam Chair.
Absolutely. Delegate Hill.
Thank you. Dana, I understand your argument, if I hear you correctly, that you guys negotiated this out of the bill last year, so we don't want to see it put back in based on some potential federal bill that may never pass. What I'm not understanding is why this would be additionally burdensome. When employers already get a annual thing where they actually have to list everybody in their employee. And so it just is the same thing, and it's not disaggregate. I mean, so you can't identify, it doesn't create, I'm not clear why this creates a burden on the employer, and if that puts us in a better position and we can get a sense of what percentage of folks are classified as contractors or otherwise. I just not, other than the fact that it's not what you guys agreed to a year ago, is there some other burden to the employers that would make this a challenge? Because it's not going to go into effect right away. It goes into effect October, November. We could always move the date also.
Right, but I think that was the issue. I mean, I think there's an overarching issue. I mean, the state does allow residential service agencies to use independent contractors. I don't know the percentage of what is being used, but again, based on the legislation that we passed last year, it will give information on how many residential service agencies use independent contractors. And that was what we had negotiated last year. You know, and I will say in the association, we have a mix of those who use independent contractors and those who only use W-2s, and there's strong feelings on both sides. So even within the association, it was a careful negotiation. But there is strong feelings that the actual wage should not have to be reported for the independent contractors or for the employee. I mean, we have the minimum wage. And there are already the laws and the attestation that you are complying with those.
Thank you. Do we have any more questions from members of the committee? I don't see any more hands up. So Dana is the last person to testify on this bill, I think. Yep. Okay. So that concludes the hearing on House Bill 544. Thanks, everyone. The next bill is House Bill 912, Delegate Sample Hughes, Health Insurance Provider Panels, Coverage for Non-Participation. Delegate Sample Hughes.
Thank you, Madam Chair, and good afternoon, Chairman Pendergrass and Vice Chair Pena-Melnick. Today, I am asking for a favorable report on House Bill 912, which reduces cost barriers to mental health and substance use disorder treatment for consumers and incentivizes the carriers to increase the number of substance use and mental health providers in their network. Currently, under state law, consumers who cannot get access to medical services without unreasonable travel or delay may request approval from their carrier to go to a non-network provider. Even if they get that approval, the consumer will still pay more for that service than if it were delivered by a network provider. The patient will pay the in-network cost sharing rate, but they can be billed the difference between the provider's bill and the carrier's payment. This shifts the cost from the carriers with inadequate networks to the most vulnerable of their consumers, as well as removes any incentive for carriers to grow their networks. If you recall, back in 2020, I did introduce similar legislation, but at that time I received pushback from the carriers who felt that the legislation was unfair and unnecessary because they were already doing their best to improve their networks. They said that the mandating of out-of-network coverage would cause complications. However, 2 years later, their networks continue to be woefully inadequate. If I could just highlight for you that the letter of opposition that you have in your file today from Kaiser Permanente, it does speak to the point that they have expanded their network. However, it will be good for all of us to learn how they did that and what were the best practices to bring in individuals into their network. But again, during that time in 2020, I tried working with the carriers to find the ways to make this bill palatable. And so today, House Bill 912 does not include any legislated reimbursement rate, but instead what it does, it has the Maryland Healthcare Commission to lead a transparent and open process, literally, to look at what a formula would be for all involved and have the stakeholders at the table. That would include our patients, that would include the providers and the carriers. But again, still some carriers are opposed to this process. We have over time, had those conversations about figuring out how to improve the networks, but often I think even our committee has heard that they are claiming that the providers are the problem, that they don't want to come into the network. And in my research, I have noted that there are 17 other states that offer balanced billing protections, and that's according to the Parity at 10 group. So you will hear today from providers who have been wanting to get into the network, and they will share with you that that's not the total case, that they don't want to be in, but there's been barriers and there's been challenges. So if I may, for just real briefly, is just highlight for you some of the mission statements that I have garnered from a couple of our providers or carriers. Kaiser Permanente exists to provide high quality, affordable healthcare services and to improve the health of our members and communities that we serve. Care First, our values serve as a pillar for all that we do that guide our company's dedication to maximizing our community's access to high quality, cost-effective healthcare services. And they say they do this through the eyes of their customers. The last one that I think is pretty interesting is Aetna, where it speaks to helping people achieve their health and financial security for providing easy access to cost-effective and high-quality health care. And then I said the last one, but Cigna, their statement was letting you choose how, when, and where you want that service. So frankly, this has gone on for too long. And the original version of this bill, as I said, was introduced, but it was actually introduced by the Hogan administration because they too saw the coverage gaps and decided that they needed to make this a priority. So since then, thousands of Marylanders have been living their lives and in many cases suffering because of the inaction and the delay tactics of the carriers. So expanding the networks has been a priority of this committee. And since I have been elected, and I know that we have solutions right here within if we work together to make sure this is no longer a challenge in the state of Maryland. I urge your favorable support for House Bill 912, and thank you for your time. And you'll have the opportunity to listen to other persons of like-minded concerns. Thank you.
Thank you very much, Madam Speaker Pro Tem. We have, I believe, all four panelists here for this bill. The first one signed up is Babek Emanuel. Hope I got your name right.
Close enough. Bye-bye, Emmanuel.
I did my best. I apologize.
Yeah.
Go ahead.
Good afternoon. Should I go ahead?
Let's do.
Good afternoon. My name is Babak Emmanuel. I'm a physician specializing in addiction medicine. Thank you for the opportunity to submit oral testimony in support of the House Bill 912. I'm here to talk about the lack of in-network providers for commercial carriers, as I have experienced it. I've been practicing addiction medicine on a full-time basis since 2007. I'm currently operating 2 opioid treatment programs, one in Carroll County and the other one in Northeast Baltimore City. When I opened up my first program, the one in Carroll County, I heard loud and clear from other providers that they had such a difficulty getting contracts from the commercial carriers that they shouldn't even bother trying. This was in 2007. For over a decade, I made no attempts to get paneled with any of the commercial carriers for that reason. In mid-2020, we heard that a small opioid treatment program in Pikesville became paneled with a commercial carrier. And that's when I decided to give it a try. I figured the opioid epidemic and the rise of drug overdose deaths may have changed things with the commercial carriers. So on August 31st, 2020, I sent an application to one of the commercial carriers asking to become paneled with them. From August 31st until March 29th, 2021, I exchanged over 45 emails and about half a dozen phone calls. Each time they asked for a document or additional explanation, it was provided to them within 2 business days. On March 29th, we finally received our contract and thought it was cause for celebration. However, when we started to read the fine print, we realized that the rate that they offered was not only lower than the cost of the medication we used, it did not provide any reimbursement for individual counseling or reimbursement for the physician's visits. Please understand that counseling and periodic physician's visits is a state and federal requirement for our program. Despite me raising these issues with the carrier, I was told to take it or leave it, and there would be no negotiations. When I asked that their rate would not even cover my medication cost, the response was that their fees schedule was derived from data analysis, including but not limited to market validation analysis, having been performed by an outside third party. I know you hear from the carriers that they have tried everything they can to build an adequate network. What I have experienced directly is different. I am personally aware of at least 7 other programs that are very interested in having a contract with commercial carriers. They have decided not to pursue such thing as a result of my experience and other similar experiences. Thank you.
Very much. Andre Pellegrini. Is Andre Pellegrini here?
Yes, I am, and I was
Excellent.
muted. I'm sorry about that. Hi, my name is Andre Pellegrini. Thanks to the chair and members of the committee to taking my testimony in support of House Bill 912. My name is Andre Pellegrini. I'm a provider of outpatient and inpatient substance abuse and mental health in Baltimore City. The concerns that I have about the coverage of behavioral health by commercial carriers is common among providers in Maryland. And the following issues are the most concerning to all of us. The first one, as Babak was saying, is the difficulty in becoming paneled with commercial carriers. Just for you guys to have an example, I tried to become in network with a certain carrier, and I'm not going to mention the name, for 6 or 7 months. That's how long it took me to get a contract with this particular carrier. And in the meantime, I was providing care for these patients and hoping that I would be able to bill for these patients as out of network until the contract was approved. Another carrier, it took me 6 or 7 months also, and it was the same difficulty. There were always something. They would not reply to emails. They would not get my calls. It was nearly impossible. Another provider that I know, it took her 1 year to get paneled with another carrier. And after the 1 year, the patient was not even there. This particular commercial carrier's patient was not even there. That's the first difficulty. It's so hard to get contracts with the commercial carriers. The second issue is that a lot of carriers require referrals to mental health and substance abuse services, which is really detrimental to patients. Once we get a contract, if we can get a contract, there is such a high administrative burden to deal with commercial carriers. They find so many reasons to deny claims for substance abuse and mental health treatment. It's very shameful. And lastly, as Babak was also saying, the rates. Providers do not know how much commercial carriers will pay for the services that we provide. We don't even know what services they will cover. So it's really doing business in the dark. Thank you so much for taking my testimony.
Thank you for your testimony. Courtney Bergen.
Hi, can you hear me?
Yes, thank you.
Good afternoon, Madam Chair and members of the committee. Thank you for allowing me to testify on House Bill 912. My name is Courtney Bergen. I'm a Baltimore City resident and a student at the University of Maryland, Francis King Carey School of Law. But more importantly, I'm a consumer of mental health services, and my ability to access appropriate mental health care nearly cost me my life. As I urge you to support House Bill 912 so that other consumers don't run into these issues. I spent almost 4 months contacting more than 50 mental health providers, yet not one in-network provider had the availability, willingness, and expertise to assume my care. Because many providers deemed me high risk due to a history of repeated trauma, hospitalizations, and a rare complex medical condition. Thus, I attempted to obtain authorized out-of-network care, which insurers are required to cover under existing Maryland law. However, my insurers refused to negotiate with me and my providers, putting an inordinate administrative and financial burdens on both of us. Unfortunately, because of this, it was going to cost me more to seek in-network care under this authorization with an out-of-network provider than it would have to just use my out-of-network benefits. Thus, because of these loopholes within the existing laws, it took me almost 2 months to get an authorization, and that only happened after I testified in front of the Senate Finance Committee. But unfortunately, less than 4 months later, my insurance changed and the whole saga started over again. I ended up in the hospital and my insurer incurred over $135,000 in hospital costs. While eventually my insurer agreed to negotiate a single case agreement with my outpatient providers, in that interim, I was set back a year behind the rest of my cohort in school. I lost the ability to celebrate Jewish holidays with my community, and it unnecessarily uprooted my life. I wasn't sure whether I was going to be able to obtain the care that I fought for and sought for almost 2 decades that it took me to obtain in the first place. Now that I have appropriate care, I really want to emphasize the benefit. It has given me opportunities that I never imagined even possible. I have successfully completed 3 semesters of law school, and in my 4th, I had a 4.06 GPA last semester. I have a stable place to live. I have supportive friends, and I haven't required hospitalization since the last time my insurer refused to provide access to appropriate mental health care.
I'm going to have to ask you to wrap up. Thank you. Do you have a sentence to wrap up with? I thought it was a nice note to end on.
Yes, I urge you to issue a favorable report on House Bill 912 because all Marylanders deserve access to these same opportunities.
Thank you so much for your testimony. Ellen Weber.
Thank you, Madam Chair, and thank you, members of the committee. I'm Ellen Weber with the Legal Action Center on behalf of the Maryland Parity Coalition. Thank you for the opportunity to testify in support of HB 912. And we thank Delegate Sample Hughes for reintroducing this bill to protect consumers from unaffordable out-of-pocket costs when they can't find a network provider within a reasonable time or distance. As others have said, Marylanders have a right under Maryland law to get carrier approval to see a non-participating provider when a network provider is not available. But this right is actually meaningless because consumers can be balance billed for the non-network service. That's the difference between what the provider charges and what the carrier will pay. Few consumers can afford that. Under HB 912, plan members will get the full benefit of state-mandated mental health and substance use disorder benefits, ensuring that they pay no greater cost than the cost of a network provider. And to ensure that non-participating providers can afford to deliver these services, HB 912 would require the Maryland Healthcare Commission to establish a reimbursement rate formula to ensure a fair and defined reimbursement rate. Providers will not have to negotiate an agreement for each individual, expediting entry into care and the actual promise of reimbursement. 17 states from across the political spectrum have adopted the no greater cost standard, including our neighbors Delaware and West Virginia. It is also based on the National Association of Insurance Commissioners Model Network Access and Adequacy Act. This is a fair and right policy. After 6 long years of trying to address limited networks through legislative and regulatory activity, consumers should not bear the cost burden of inadequate networks that they have no control over. This is particularly true when they pay high premiums for network services. Consumers should not have to pay twice. The state has taken very important steps to address limited access to behavioral health care, but much more can and must be done. HB 912 offers a necessary remedy for all Marylanders who are experiencing the greatest need ever for behavioral health care. We urge a favorable report on 912 to level the playing field and ensure that Marylanders get the behavioral health benefits they pay for without life-threatening delays. Thank you very much.
Thank you very much. Questions from the committee for this panel of proponents? I see a question from Delegate Johnson.
Thank you, Madam Chair, and thank you, sponsor, for bringing this bill. And I want to just say this is not a new concept. Our VA hospitals promoted legislation just like this. If they could not, our veterans could not get into the VA hospitals, within 30 days, they could go to an outside source for care. And I want to make sure I'm clear. I guess this is to the sponsor of the bill. Now, as a state, we invest in the reinsurance so more people can get on insurance. But then when they can't get adequate care in an adequate time, they have to go out of network and still pay their premiums, but pay much higher costs. Is that correct?
Yes, that's correct, Delegate, and thank you for the question. But yes, with that reinsurance bill that we passed, I believe it's 2018, that would allow, the carriers to be compensated for those higher cost individuals. Would think that it would help the problem that we have at hand, but that's really not the total case here. So to that end, yes, you're correct.
Thank you. Thank you, Madam Chair.
Questions from the committee. Delegate Riley.
Thank you, Madam Chair. Yes, with this bill, okay, so are you saying that if the network that they belong to does not have the physician for behavioral health, then they have to go outside of network because there's no behavioral health provider for them to see, then that should be allowed and they shouldn't have to pay the high rate. Is that what this bill is saying? Or is it saying that they do have behavioral health physicians within the network, but yet they can't see them because they're, overly crowded and they, within a certain amount of time? I kind of got a little confused with your follow-up to Delegate Johnson's question. If they have a provider and they can't be seen within a certain amount of time, then this bill will go into effect. So does the network have a provider for them to see, or do they not have a provider they can see? And we're allowing a time frame.
Sure, I'll let Ellen take that. I see her nodding, so I'll go ahead and let her take that one.
Sure. Thank you, Delegate Riley, for that helpful question. There are 2 situations that Maryland law already provides for. So under insurance 15-830, it's both of the situations that you've identified. The carrier, if it does not have a provider who has the ability to provide services because they don't have that expertise in their network, the carrier is required to give approval to go to a non-participating provider. But in addition, under the state's network adequacy metrics, if a network provider cannot deliver those services within a reasonable time and distance, and Maryland law defines what that is, then that is also another opportunity and another guaranteed right to get approval to go to a non-network provider.
Okay, so this bill covers both scenarios.
That's
okay,
right.
That's wanted to make sure.
Yes, the main thing to know is the member has to get the carrier's approval. This is not just a situation where I choose to go to a non-network provider. It is because I want to go to a network provider, there isn't one available, and I get approval to go to that non-participating provider.
Okay, thank you very much for clarifying that.
Thank you. I don't see any further questions for this panel. So thank you very much to this panel, and I will call up the panel of unfavorables. We have Matt Celentano and Allison Taylor. Who would like to go first?
I'd be happy to go, Delegate Kelly. Thank you, Madam Chair and members of the HGO Committee. My name is Matt Celentano, here today on behalf of the League of Life and Health Insurers of Maryland in respectful opposition to House Bill 912. We understand the frustration of the advocates. We are certainly frustrated as well, but we are making progress. And we believe that this bill would stop a lot of that progress. Since we last had this conversation in 2020, carriers have made strides to improve the situation. Most carriers were not meeting the network adequacy standards last time we talked about this, but we are now. We are making significant strides. Are we there yet? No, but we are making lots of improvements day by day. Carriers are expanding networks. We're continuing to innovate in the space as well. There are new partnerships, expanded and dedicated behavioral health call centers, as well as app triaging. The world is changing. We will get you an appointment today if you want one. This committee has added social workers and expanded scope to help alleviate the challenge, but we still have not solved the problem. There's certainly still work to do. There are a lot of approaches this year in the General Assembly to address healthcare shortages. We have been here before this committee saying this for years, especially in this space. The lack of providers is a significant hurdle in this discussion. Just to be crystal clear, there are not enough behavioral health providers in Maryland to meet the needs of the population, and this bill does nothing to address that. For example, even if every single carrier contracted with every single child psychiatrist on the Eastern Shore, we would still fail to meet the standards. Unfortunately, carriers can do nothing to solve this. This bill would also look to mandate payments out of the networks. This is completely counterproductive to the work carriers have been making to expand the networks, and will take away any incentive from a provider to join a network. How do you negotiate a rate if there's a mandated rate? Why would you join a network when you can operate outside of it and not have to deal with the red tape and are guaranteed a payment? For these reasons, we respectfully request an unfavorable report on House Bill 912, but we'll continue to try to figure out innovative ways to solve the problem. Thank you.
Very much. Allison Taylor.
Good afternoon, Madam Chair, members of the committee. I'm not sure why you guys can see my virtual background, but you can't seem to see me. So anyway, I'm here and respectfully in opposition to House Bill 912 today. I do want to thank Delegate Sample Hughes and these advocates for speaking with us last week. And I've taken some notes on the concerns I've raised that I can bring back. I think the issue that we're concerned about is in the title of this bill, coverage for non-participation. We see something like this that creates a special rate for providers who do not participate in our network as providing a barrier to getting providers to come in network. As Delegate Sample Hughes noted, we've made some substantial strides in the last couple of years to improve network adequacy. We've opened a couple of new healthcare facilities. We've contracted with additional providers. We've hired additional providers in the Permanente Medical Group. And I've put my email address here on my little Zoom square. So if anyone has questions or would like to speak about working with Kaiser Permanente, to please reach out to me after the hearing. Anyway, I think what would be helpful in this situation is to get a little more granularity on what the problem is. Is it a certain set of providers that are having trouble with this, or is this reflective of the community overall? How many providers are out there who are in network and aren't in network? As we know, there's a lot of behavioral health providers who don't take insurance at all, and that remains a frustration for us in terms of improving our networks. So I'll wrap up and just say we're here to be partners. We do not like this specific approach, but remain at the table and request an unfavorable report.
Very much. Questions for this panel. Delegate Johnson.
Thank you, Madam Chair. And this question is for Matthew. Matthew, you say you're making strides, you're getting better, but with people with mental disorders who need care today, now. So if you cannot facilitate the care they need when they need it, and they can find someone out of network who can, and they have to get permission to do that, why would you have an issue with that?
So, Delegate Johnson, thank you for the question. Let me clarify on the in-network, out-of-network with folks that are seeking care. One, every single one of the carriers now has a 24/7 hotline. And if you call and are in need of an emergency appointment, they will not let you off the phone until they find you an appointment. Now, it might not be exactly the carrier you want, but they will find you an appointment. If you prefer to go out of network, this is what happens, Thursday. If you go to out of network, the carrier will try to enter into a single case agreement with that provider to limit the consumer's cost sharing exposure. In the long term, it would be much better that we could keep the folks in the network or try to get them to come into the network. So if they do go out of network, the carrier tries first and foremost to try to get the provider to come into network. If that is not possible, we try to negotiate a fee with that actual provider and try to make sure that the consumer is held harmless. We always try to get the consumer to be held harmless and not balance billed. When you get that agreement, that single case agreement, they bill the carrier directly and not the member. So we pay them directly. It is probably a little wonky way to get it done, but it is effective. I think a lot of the discussion we're having here is that some of the providers don't like the rate. Regardless, it is not going to change if we can't expand the world of providers or be able to contact every possible provider to try to contract with them. And we are doing that and have been doing that for years and will continue to do that. But there are hold harmless provisions already at play here.
One follow-up pertaining to the question, Madam Chair. Are the rates that you're offering, is that what is prohibiting providers from coming in network?
I don't think I could speak to that, Delegate Johnson. That would be a carrier to provider type situation. I will say that one of the proponents suggested that there were 17 states that had this approach, and we asked for that proponent in the meeting that we had prior to this hearing to send those over. She did not, and we tried to scrub, and we found no approach anywhere in the country that matches this bill.
Thank you, Madam Chair. Thank you, Matt.
Any more questions from members of the committee? I don't see any more hands up from committee members. I'm sorry, Dr. Emanuel, we can only take questions from members of the committee. So with that, I think we will conclude the hearing on House Bill 912 and move on to House Bill 709, which is Delegate Robin Lewis, Maryland Health Benefit Exchange, Small Business and Nonprofit Health Insurance Subsidies Program. Delegate Lewis.
Thank you, Madam Chair. And thank you, esteemed colleagues of the Health and Government Operations Committee. For the record, Delegate Robin Lewis, on behalf of House Bill 709, entitled Maryland Health Benefit Exchange, Small Business and Nonprofit Health Insurance Subsidies Program. This committee knows better than anyone in the General Assembly how hard we've worked to expand access to quality, affordable healthcare insurance coverage. We've done groundbreaking, innovative approaches like the easy enrollment provision or bill of 2019 that allows Marylanders to simply check a box on their tax returns to get access to health insurance coverage. We've halved the uninsured rate in the state of Maryland since the Affordable Care Act became law. And yet there are still pockets of people, hardworking Marylanders, who remain uninsured. This bill reduces some of those barriers and expands access to quality and affordable care. House Bill 709 is cross-filed with Senate Bill 632. So how does the bill work? Well, starting in fiscal year 2024, this bill will invest $45 million per year into a 5-year state subsidy program for
Richard,
small
can you pause
businesses.
the timer for a second? There's someone who needs to put themselves on mute, and I think it's distracting for the committee. I'm sorry to interrupt you, Delegate Lewis. I just want to make sure people could hear you. Thank you. Go ahead, Richard.
Thank you. And maybe let me turn up my volume a bit. Hopefully that helps a little.
Thank you.
So thank you. Starting in fiscal 24, this bill will invest $45 million per year into a 5-year subsidy program for small businesses. Small businesses being defined as those with fewer than 25 full-time equivalent employees. The workers at these small businesses, these qualified small businesses, will be offered coverage through the Maryland Health Connection, the agency through which our state implements the Affordable Care Act. So this bill will strengthen small businesses by helping them to expand access to healthcare for their workers. In addition to the premium subsidies, this bill will also invest $3 million every year in outreach to make sure that small employers are aware of the program. We envision that the funds for this program will come from available federal funding. I'll mention here that in conversations with stakeholders, we want to clarify that the Small Business and Nonprofit Health Insurance Subsidies Program will not use reinsurance or premium assessment funds. There are other sources of funding, the federal, state, and local level, that will be applied to make this work. Again, this bill defines small businesses as qualified employers with fewer than 25 full-time equivalent employees. That includes nonprofits in our state. And I think when we talk about small businesses, it's critical to remember that in Maryland, which has one of the highest per capita rates of small businesses, in Maryland, small businesses really include African-American owned, Hispanic owned, Asian owned, and women owned businesses. People of color in Maryland own the most small businesses in the country per capita, and yet health disparities persist in these communities. So small business owners can be partners in expanding access to care, but we have to make it work for them. Before the COVID pandemic, working people looked for jobs that offered good pay and good benefits. Then, as now, big employers can usually outcompete small employers when it comes to offering an attractive package and meet worker expectations. In Maryland, only 30% of small employers are able to even offer health coverage compared to 95% of their larger counterparts. So when the original SHOP program was created, the Small Business Health Options Program was created under the ACA. Tax credits were supposed to help small businesses bridge that gap. That program didn't meet expectations here. This bill will allow us to strengthen small business, expand healthcare, and really make it work. With that, I respectfully request a favorable report.
Thank you very much, Delegate Lewis. Let's hear from Vinnie DeMarco.
Thank you, Chair Kelly, Chair Pendergrass, Vice Chair Pena-Melnick, and thank you, Delegates Robin Lewis, Brooke Learman, and Karen Lewis-Young for sponsoring this bill. We need to help small businesses get healthcare. As Delegate Lewis said so eloquently, especially led by this committee, the Maryland General Assembly has dramatically improved healthcare in our state, cutting in half the number of uninsured, but there is more to do. In 2007, even before the Affordable Care Act was enacted, you enacted the Working Families and Small Business Health Care Act, which created the Small Business Partnership, which dedicated $15 million per year for subsidies for small businesses. That had hundreds of small businesses across the state benefited from that. That was discontinued when the Affordable Care Act started because of the tax credits that Delegate Lewis mentioned. Now we need to create a program like the 2007 programs because the tax credit just isn't enough. And what we need to do is make sure that the exchange, which by the way is the best exchange in the country, we believe, has the resources to reach out to small businesses and let them know that there are resources available and that we have the money to provide the subsidies that the small businesses need. As Delegate Lewis said, only 37% of small businesses can provide healthcare coverage for their employees while 95% of large businesses do. We want to help those smaller businesses with less than 25 employees. And we have been listening to stakeholders who were concerned about money in the out years. And that's why there's a 5-year sunset after which the legislature can look at this again. And we believe that this bill will help to fill the gap that we still have left of uninsured in Maryland. Maryland's the 5th best state in the nation in healthcare, and we can become first with measures like this. Thank you for a favorable report on House Bill 709. Thank you very much.
Thank you. Perfect timing. Next is Pete Barron.
Thank you, Delegate. Good to see everyone. Pete Barron with County Executive Stuart Pittman in Anne Arundel County. I want to thank the sponsor, and I won't repeat what the sponsor or Vinny did, and I don't think there's any way I can meet his perfect timing, ending right on the buzzer there. But I am, one of the things that the county executive says all the time is health is one of the most important things. And this bill will help people get access to health care. Also, it will help our nonprofits and our small businesses. That's why the county executive has endorsed this idea, as well as County Executive Calvin Ball, County Executive Elric, County Executive Barry Glassman, County Executive Olszewski, Mayor Brandon Scott, County Executive Gardner, and also Brooks. Did I get them all, Vinny? So hope you will move this favorable. Thank you.
Thank you, Pete. Always nice to see you. Let's hear from Henry Bogdan.
Thank you, Madam Chair. Henry Bogdan, representing Maryland nonprofits. We're here to urge you to support House Bill 709. Everything's been said about the conditions of small businesses. I can tell you that the situation for small nonprofits in the state is either parallel or perhaps even worse. We did a survey of 700 organizations at the end of 2000 to see the impact of the pandemic. 65% had reductions in revenue. 35% had either furloughed or laid off staff because of reduced revenues. We're in the same market trying to compete for employees and compete for staff. The ability to offer benefits is often the thing that makes it possible for a nonprofit to grow beyond a single staff person or to hire that initial staff person. It's critical. The tax credits have not had that much impact here. There are provisions in the federal law about average wages that might have worked fine in Mississippi, but they don't tend to work as well in Maryland. So we just appreciate a favorable report.
Thank you. We have William Chambers.
Thank you, Madam Chair, Chair Pendergrass, Vice Chair Pena-Melnick, members of the committee, and thanks to Delegate Lewis for sponsoring this critical piece of legislation. Bill Chambers, I'm president of the Maryland Association of Chamber of Commerce Executives, and on behalf of our 31 member chambers of commerce spanning across the state from Garrett County to Ocean City and representing more than 15,000 businesses that these chambers represent, the majority of those members are small businesses in our state. We support House Bill 709. As has already been talked about, 63% of small businesses in our state cannot offer any kind of small group insurance plan for their employees. This is an opportunity to change that dynamic. This is an opportunity for small businesses to grow and excel even more than they are in our state. Small businesses, as you all know, are the backbone of Maryland's economy. Being able to have the ability to offer their staffs health insurance at reasonable rates is critical for our competitiveness as a state as we continue to try and claw our way out of the pandemic, and all of our small businesses are working hard to do that. We also recommend that the amendment be added to the legislation that would add the 5-year sunset provision, so everyone will know what the landscape looks like after the subsidy ends. Companies will be able to make future investment decisions, or conversely, the General Assembly could vote to extend the subsidy payment. So we strongly urge a favorable report on House Bill 709 to help grow our small business community. Thank you for your time.
Very much. Jamal Lee.
Thank you, Madam Chair and committee members. So yeah, my name is Jamal Lee, and I'm a small business owner in Laurel, Maryland. And as a small business owner, offering health coverage is one of our top priorities. I know how important it is, and I know how it attracts a high caliber of employee. But in the current economic climate created by current COVID-19, it's more important than ever to offer health coverage to our employees. But on a more personal note, back in December 2011, my wife and business partner needed emergency surgery, and I found her on the floor drowning in her own fluids. And she had an infection in her fallopian tube, and she needed emergency surgery again there. That poison had spread throughout her system, and it almost killed her. I was able to get her to the hospital, so I often tell her how I had saved her life, and it kind of, I don't know if it goes over well all the time. But anyway, but it was because I was freely able to get her to the hospital without any concern or of location or coverage, and she got immediate care, and it really made a difference across the board in her life. For me, this bill is life-saving, and I have a history to say it works for us. And as a representative of businesses around the country, it's important to us. But more importantly, I don't know how I would run this business without having my wife at my side. So thank you again for your support of quality, affordable health care, and I hope I can count on your support of House Bill 709.
Thank you very much for your testimony. That concludes this panel of proponents. Do we have questions from the committee? I see a question from Delegate Bagnall.
Thank you, Madam Chair, and thank you to the bill sponsor. I love this bill. As a county with 80% of our businesses small business, and coming from an arts nonprofit world, I know how essential it is. But my question is, I believe that it is, but the agricultural community isn't sort of spelled out in the bill. Would small farms that had full-time employees be eligible for the subsidies under this bill? Whoever's most qualified to answer. I saw Mr. Chambers nodding his head. So.
My understanding is absolutely. If you're a small business, you're a family farm stand, which we have 1,600 of them across the state. You're the same kind of small business as the shoe repair guy down the street.
Thank you. Thank you so much, Madam Chair.
Thank you, Delegate Krebs.
Thank you. And I'm not sure who can answer this on the panel, but I guess one of the small business folks, earlier this week, I believe, we have a bill about reinsurance, and this reinsurance pool, which is very confusing to understand, but as simple as it is, it imposes a tax on these very premiums. They call it an assessment, but it's a tax on these very small business, individual market people that we're trying to help here. So I guess on one hand, we're asking for this money to come in to subsidize this tough market. But on the other hand, on this other bill, which we've already added this extra tax on, everyone seems in favor of that too. So it doesn't seem, tell me if I'm wrong, that on one hand, we're taxing this very same group of people to help lower premiums for other folks. But then on this, we want this same group of people to get a break on taxes or a break on their premiums. So I'm not sure if anyone in the group can explain this dichotomy of what we're trying to do with these very same folks. And if the small business community and individual market folks understand that it doesn't make sense to me.
Thank you. Thank you so much, Delegate Krebs. I really appreciate that question. And thank you for giving me the opportunity to clarify something really important. This bill has nothing to do with the reinsurance bill that we debated the other day. This bill doesn't impose taxes on anyone. It doesn't impose assessments on any entity. This bill will be funded through federal dollars, wherever those may become available. It is not funded by taxes or assessments. There's a clear, bright line between this bill and the reinsurance bill.
No, I understand. That wasn't my point. I won't make it further here. That was not my point. But thank you.
Thank you. Thank you. Thank you.
Thank you. Delegate Shalega.
Thank you so much. So as a small business owner myself for 30 years, I firsthand understand how hard it is to provide health insurance for your employees and how deeply small businesses care about the people that work for them. They're like family. And this bill is not addressing cost. It's just addressing subsidies. So I'd say, Bill Chambers, you might be the right person to answer this question. The association bill that comes in every year that allows your businesses in your chamber to join a national association that would focus on cost, not subsidies. How would you compare those two?
Well, thank you, Delegate. It's a great question, and other members of this committee and the General Assembly have asked us this question. We pushed, as you all know, association health plan legislation the last few years. Senator Edwards was one of the sponsors of that bill. We kind of gave up on that. It wasn't something that generally the General Assembly seemed favorable with. We had a bad experience, as many of you know, back in the 80s and 90s. It was kind of the wild, wild west, and people were left on the sideline without insurance. AHPs have had a mixed bag of reviews in other jurisdictions of the states that have adopted these. We, at least our association, and former Delegate Rick Weldon and I met with Care First and some of the other carriers and decided the best way to do this was to work with the exchange to try and figure out a way to make the small group market more affordable. It was then we found out from Senator Feldman that this piece of legislation was in draft form, and this may address the concerns that the small business community has had for decades in terms of affordability. So that's one of the reasons why we immediately jumped on board and said this is a smart piece of legislation to support, and we're not going to pursue the AHP piece. We think this is probably the better way to do it and the more comprehensive way to do it.
Well, thank you for your opinion on that. I still would reinforce this is based on subsidies, which means you are not addressing cost. And cost is the huge factor here. If you bring it down for a couple of years or 5 years, pie in the sky, the feds are going to drop money from heaven. It doesn't address the bottom line, which is cost.
Yeah.
Thank you.
Yep. Yeah, no, correct. That is the issue. I hope that maybe a study group can be convened if this bill is passed, to look at what do we do when we get past year 5, because all of us don't want to be back in the same boat we're in today 5 years from now.
Thank you. I see no further questions from the committee, and no one is signed up in opposition to this legislation. So that concludes the hearing on House Bill 709. Thank you very much. I am going to, let's see, it's 2:58. Let's call it break time. We'll break from 3 to 3:15. We will come back at 3:15 and do the last 4 bills. I was hearing some noise. I just want to make sure no one else was signed up on the bill, but no one else was signed up. So we will break. We will return at 3:15 to do the last 4 bills of the day. Thank you, committee. Okay, everybody, we're going to get started in 30 seconds. I see Delegate Hartman is already here. Thank you so much for being prompt. And I'm sorry our HGO break started right before your bill hearing. So I appreciate your patience with us. I'm just going to make sure we have enough members back to get us started.
It's the way my day has been.
Perfect. Okay, we have plenty of committee members to go ahead and reconvene. So let's hear from Delegate Hartman, House Bill 675, Health Insurance, Changes to Coverage, Benefits, and Drug Formularies, Timing. Delegate Hartman.
Well, thank you, Madam Chair, Madam Vice Chair, and members of the House and Government Operations Committee. For the record, this is Delegate Wayne Hartman with House Bill 675. As you mentioned, the bill is titled Health Insurance, Changes to Coverage, Benefits, and Drug Formularies, Timing. Hate to jinx the bill by saying it's a simple bill, but it truly is a simple, common sense piece of legislation that would prohibit the, basically prohibit the time as when changes can be made to the coverage of services or benefits provided under a health insurance policy or contract during the term of the policy or contract. So it would only allow changes on the renewal of the policy or contract. It's very similar for prescription coverage. It provides a coverage for prescription benefits, may not remove a drug from its formulary, move a prescription drug or device to a benefit tier that requires a higher deductible or copay or coinsurance during the term of the policy or contract, and a carrier may only do so at renewal. One note on this, with the drug benefit portion, it would allow them to add by the wording, but I have requested an amendment to the bill already that would allow addition to the first part of the bill as far as services covered. So there was a note in the fiscal note that this bill may cause limitations in not being able to add services. So of course we want to provide whatever benefits we can through the language in the bill. In the past year, our office had 2 constituent cases that prompted this bill. And as a little side note, the state employee and retiree health plan only makes changes at the renewal date. So I think it's only right that we afford as many people as possible that same benefit. You'll hear from a family that made their selection based on the coverages because it was very, the need that they have was very particular, and this policy covered it. Those changes made during the year excluded the benefit that they were using and created a huge hardship for the family. So I urge a favorable report, and I'm confident that the testimony here will be very compelling. Thank you.
Very much, Delegate Hartman. I'm calling up Sarah Roderas.
Hi, good afternoon. My name is Sarah Roderas. I'm a Maryland resident in support of House Bill 675. Thank you to Delegate Hartman for sponsoring, and thank you for allowing me to testify. In October of 2013, our son Doug was diagnosed with multiple sclerosis. After 3 hospitalizations over 4 months, the medication prescribed had built up in his system and began working. He continued with school, playing football, even finished his senior year as an all-county center. He's now attending Salisbury University and thriving in their business program. No hospitalizations for 8 years. This past year, we went through our open enrollment with our insurance provider, and we confirmed that the same medication, same coverage, and same doctors were included, and we committed to another year. 6 weeks after locking in the decision and open enrollment closed, we were notified that the insurance provider would no longer provide his medication that was on the formulary list during open enrollment. We began filing appeals. His world-renowned Hopkins MS neurologist also filed an 18-page appeal. Every appeal was denied. After support by our amazing Maryland representative, the insurance provider agreed to allow Doug to stay on his medication for the remainder of the plan year. Once an open enrollment period closes, we no longer have a choice to switch to a different plan until the following plan year. I feel it's unethical to remove medication or modify coverage once open enrollment closes. I am very much in support of House Bill 675 to ensure those providing Maryland insurance coverage make the same commitment to Maryland subscribers, just as we do when committing to a plan year. Thank you.
Thank you very much for your testimony. Next up is Dana Kaufman.
Thank you very much, Chair Kelly, members of the committee. For the record, my name is Dana Kaufman. I'm here in support for MedChi on this bill. And the stories that I want to tell you are very similar to what you just heard. And I do want to recognize that Maryland, from legislation from a couple years ago, did look at this issue, and we put in an override provision that if a formulary or plan changed coverage, then there had to be a process to request an exemption. Unfortunately, that process seems to be having some difficulties with getting exemptions. Unfortunately, I had a doctor today who wanted to come but couldn't change her patient. She's a rheumatologist, and she provided me with two examples that I think are very telling. So basically last year, a large PBM in the state changed coverage for treatment for rheumatoid arthritis. They changed and limited the milligrams and frequency of the dose that was allowed on the formulary originally. Through the appeals process, the physician went through and it was denied. And unfortunately, the patient had a health decline. The second was a requirement after a formulary change that in order to have the exemption approved, the physician had to show a percentage of improvement of the patient since being on the drug. The patient had been on the drug for 3 years and had been stable. Unfortunately, stable wasn't enough, and she couldn't show that it was a percentage improvement. So the patient was taken off and again has since had a decline. I mean, I think the issue here is that, as you just heard, patients are not allowed to make a change mid-year like they can in other change of status. And they go on this medication in order to, when they choose their plans. I think it is important to take another look at the ability to make these mid-year changes because it's the patients that are suffering. Thank you very much.
Thank you very much. That is the last panelist in our panel of proponents. Do we have questions from the committee? Just waiting a second to make sure there aren't any questions. Okay. With that, let's move on. We do have a pretty hearty panel of opponents. Let's hear from Matt Celentano.
Thank you, Madam Chair, members of HGO. My name is Matt Celentano, here today on behalf of the League of Life and Health Insurers of Maryland and AHIP, America's Health Insurance Plans, in respectful opposition to House Bill 675. Prescription drugs represent the largest segment of the premium dollar. CMS projects that spending for retail prescription drugs will continue to be the fastest growing health category, outpacing all other health spending. The primary drivers of cost growth are ever-increasing launch prices for new drugs and astronomical increases on older medications that have been around for decades. One report from Credit Suisse notes that price hikes on existing medications accounted for 100% of revenue growth for 7 of the largest drug makers in 2016. It's not just the big ticket sticker shock drugs, it's the ones that have been around for a really, really long time. This bill would prevent carriers from being proactive to manage costs for beneficiaries. As you all know, drugs are commodities and the list prices are constantly changing. Maryland already requires carriers to notify formulary changes 30 days prior to adjustments. And these adjustments are crucial as drugs come online, or in some cases, we discover safety risks to consumers and must be removed. As you might remember, in 2004, the drug Vioxx was pulled off the market after, during a colon prevention study, or colon cancer prevention study, was found that the medication created heart attack risk. This bill would prevent carriers from removing a dangerous drug like Vioxx from the formulary for the year. The bill would also prevent carriers from adding life-saving drugs that come online during the year, including treatments for COVID or the vaccine. Lastly, the bill creates an operational nightmare for carriers, especially in the group space. Most contracts don't line up to the January 1 renewal. Some companies renew December 1st, some July 1st, some October 15th. It just depends on their contract. So because not all plan years have a January 1 start date and a December 31 end date, locking in the formulary for a calendar year may or may not coincide with the plan year for all enrollees that use that formulary. This would be really disruptive and confusing for purchasers and consumers alike. For these reasons, we request an unfavorable report. Thank you.
Thank you. Allison Taylor.
All right. Good afternoon, Madam Chair, members of the committee. My name is Allison Taylor, here from Kaiser Permanente. And again, I'm not sure why you can see my virtual background, but you cannot see me. But anyway, I'm here. Thanks to the sponsor of the bill and Ms. Rsas for giving us her story and giving us some background on why they're interested in this. The points I wanted to make were in line with what Mr. Celentano just said. You know, we need flexibility in the case that there is a medication that is harmful that we learn about mid-year that we might need to take off a formulary, or something that we might need to add. And one example that I would give of this is on January 15th, right after most plan years would begin on January 1st. The Biden administration mandated that health insurance companies cover at-home COVID test kits. And so it was a huge scramble for everybody, but we are covering that now. And, you know, it's because we have the flexibility to make that kind of change that we were able to do that as fast as we can. So for that reason, we urge an unfavorable report because we do not like this approach, but are happy to continue working with stakeholders and the sponsor of the bill on ways to make sure that patients stay safe and get the health care that they need.
Camille Fesh.
Thank you very much. Thank you, Madam Chair, Vice Chair, and members of the committee. My name is Camille Fesh, and I'm here on behalf of the Pharmaceutical Care Management Association, PCMA, which is the National Association of PBMs, or Pharmaceutical Benefit Managers. We are respectfully opposed to HB 675. The opposition testimony you've heard so far has been pretty comprehensive, so I'll just stick to a couple of bullet points, reiterating some of the important issues. First, this is really dealing with benefit design, and this would remove a tool in the toolkit of employers to keep premiums low and to keep healthcare affordable. And as mentioned before, the pharmaceutical world is not static. There are constantly new developments, new treatment protocols, new medicines. And because of that, the PBMs do need the flexibility to be able to add drugs mid-year, and those years happen at all different start dates. So for every single plan, it would be different. In addition, there's potential for increased prices. If a plan is locked into offering a drug at a certain copay for an entire year, if the pharmaceutical company that manufactures the drug increases the prices, then the PBM would end up stuck, and that would end up raising the premiums for the insureds. Thirdly, it was mentioned before, the famous Vioxx example. We need the ability to remove dangerous drugs from the formulary, like Vioxx. And in addition, a lot of the changes in the formulary happen because a generic comes online, and also interchangeables. Generics and interchangeables, when they come on, then those are legitimate substitutions for the brand name, which would be more expensive, which would result in a lower cost for both the patient and for the plan itself. Thank you very much.
Thank you very much. Do we have questions from the committee for this panel? Okay.
Madam Chair, if I can just correct some of the statements that were made there. There's nothing in the bill.
Delegate Hartman, we have a process in HGO, so hopefully one of the members will ask you a question, and then you'll be able to respond to that. I'm sure one of your friends will raise their hand and do that.
I hope
so
they
we can
will.
follow
Thank
our
you.
protocol. I'm sorry.
Hopefully they will. Thank you.
Yes, Delegate Johnson.
Thank you, Madam Chair, and thank you, panel, for coming to testify. Whoever is best to answer the question. What I'm hearing is that when most folks pick their plan, they pick it due to their regimen or medical regimen, the medicines they need, or financially, which plan fits their budget and most suits their needs. So when medicines are taken off of the formulary, are there always a replacement that's equal or better or generic? Are there always a replacement put back on the formulary? Because that's not what I'm hearing. So can someone speak to that?
I'd be happy to, Delegate Johnson. If a drug is removed from the formulary, I think that Camille sort of responded to this a little bit, or tried to make the point that usually it's when a generic comes online. So a therapeutically equivalent drug can be substituted for the more expensive cost drug. when you are taking a drug off the formulary, you're going to replace it with something else to treat that condition. And generally, it's a cost-saving measure.
So that is happening. There is an
That is
equal
correct.
to-
Yeah, it's not like we're just pulling off the drug because it's so expensive if there's not a replacement drug.
All right, thank you. Thank you, Madam Chair.
And I will remind the committee that we're trying to restrain from follow-ups if possible and take it to subcommittee. Delegate Hill.
Thank you, Madam Chair, and thank you all. I'm glad to hear we're all on the same side in keeping costs down. From what I heard, it seems like, and either one of you all can answer the question, that you would be in favor, if the sponsor were willing, of an amendment that would allow you to add drugs to the formulary, but not allow you to remove them in that year. For instance, in the case of Biox, you have another tool where you could simply advise the prescribers that there is a toxicity issue. And the prescriber would then say, oh, let me change that to another drug. So it sounds like, since the exemption process is too burdensome that we put in and it's not working well, that you would be okay with an amendment that would allow you to do that. Is that correct?
I'm not sure I understand. You're saying, so in the example of Vioxx, you're saying that the PBMs would be prohibited from removing it from the formulary
until the next year, but you could notify, if I write a prescription, you could notify me, there's been an FDA warning that this is dangerous. Are you sure this is what you want to give here? Just like you give me a warning then saying, this is expensive, it's cheaper if you do it this way. You can give me a warning, and then as the actual provider, I can make the medical decision about whether I want to prescribe it for that particular patient because it's worth those risks.
In this situation, I don't believe we could ever be in favor of being forced to keep a drug that has been proven dangerous on the formulary.
For less than a year. Okay, thank you.
Delegate Cullison.
Thank you, Madam Chair. I promise to be good. I think this is for Matt. Matt, you said that drug costs are are a significant percentage of the premium. If you don't have this at your fingertips, then, if you can get to us, what percentage of the premium is prescription drugs, and how much has that increased over, say, the last 3 to 5 years?
So I will try to get you the exact numbers, Delegate Cullison, but as I remember from last year, when a couple of the carriers went to the table, I think one of the larger carriers on the table, about 10 years ago, the percentage your premium was around 10 to 12% for prescription drugs. It's now at least 35%. We have seen an explosion in prices because there's no control on the manufacturer. The problem is the list prices. That is absolutely where we need to get to.
Thank you, Madam Chair.
Delegate Shalega.
Thank you, Madam Chair. This would be for Delegate Hartman. I think that you were trying to interject some question here.
Thank you, Delegate Schlegel. Yes, there's misinformation. There's nothing in the bill that prohibits a drug to be added to any of the formularies as this bill is written right now. It doesn't need any amendment for that. It says that a drug cannot be removed. Now, if something is recalled by the FDA, I don't think that drug would be dispensed, but a simple amendment for something that's recalled to be deleted would certainly be an easy amendment. But what is the testimony that's been given is very false. And as I said in my original testimony, services can't be added, which I've already requested an amendment for services to be added, but drugs can be added. As new drugs come on, they can be added. Replacement drugs can be added. So what's being said is not true. Thank you for the question.
Thank you.
Thank you for helping us out, Delegate Shalega. Delegate Saab.
Thank you, Madam Chairman. So I was reading in one of the testimony that it's bad for business and it's bad for consumer. But the question is, changing some of the stuff is also bad for the health of the consumer. And obviously we have Medicaid that's supporting it, and we have the insurance companies that are not supporting it. And Medicaid and the doctors and the providers are usually the ones that know what's best for their members. So I guess the question is, And I think there's valid points on both sides. Everybody wants to keep the cost down, but yet at the same time, we want to make sure that we're providing the right medicine for our members. So it seems like there might be some room for some amendment to make this process or to make this bill workable that benefits both sides. So the question that I have for the carriers, if a patient is stable on a medication, would you support an amendment similar to what we have for step therapy to allow patients to remain on that drug for the remainder of the year based simply on the judgment of their prescriber, other than what sounds to be like a very hard process? Would you support that?
So Delegate Saab, if I may, I'm not exactly sure how all of the carriers will react to it because I'd have to ask them, but consumers already have continuity of care protections under the Affordable Care Act. If a plan imposes like step therapy, patients and providers have a right to request exemption already. Health plans have to respond to those requests in 72 hours for non-urgent and 24 hours for urgent requests. And if the request is denied, the patients have the right to an independent appeal. Again, the response must be provided within 72 hours for non-urgent and 24 hours for urgent. So I understand the desire to get to a place where we might be able to all in agreement, but I think there are plenty of consumer protections out there. And what this bill does, if it moves forward as amended or not as an unamended, is just a giveaway to the manufacturers.
Okay, thank you. We'll finish. I guess we'll discuss this further in subcommittee. Thank you, Madam Chairman.
I did have a follow-up to Delegate Saab's question because I heard Ms. Roderis's testimony. I think we all heard that testimony. So I think that's what he's trying to get at. Is what you're saying, Matt, that the current consumer protections protect her and there is a process in place, and had she not gone to her delegate and gotten help that way, there might have been another process that maybe she was unaware of that would have met her needs? There
is already existing processes as mandated in the Affordable Care Act.
So, okay, thank you. I can't have follow-ups either. Thank you so much. That will conclude the hearing applies to all of us equally on House Bill 675. Thank you so much to the panel for your testimony on this. We're going to move on to Delegate Karen Young, House Bill 731, Department of Aging, Dementia Care Coordinator, and Dementia Care Navigation Programs. Delegate Lewis Young.
Thank you very much. Good afternoon, colleagues. Some of you may know that I've served as the House representative on the Commission for Caregiving for several years. And that assignment has given me a very strong lens on some of the challenges that caregivers endure, in particular, those caregivers that are assisting individuals with dementia, and in particular, Alzheimer's. I'd like to give you some data on the number of people in Maryland that have Alzheimer's or another form of dementia. As of 2020, 110,000 Marylanders that are 65 or over are living with Alzheimer's. And that equates to about 238,000 caregivers. More than 20% of unpaid caregivers are providing care to a loved one with Alzheimer's or another form of dementia. And more than half of dementia caregivers have been providing care for at least 2 years. 33% of caregivers provide more than 30 hours per week of care. So that's a pretty full-time job. Maryland has the third highest percentage of adult dementia caregivers. And as was mentioned in an earlier bill, we have one of the most aging populations in the country. So why do these caregivers need our support? 69% of caregivers have chronic health conditions. 28% of caregivers suffer from depression. Caregiving for someone with dementia can have negative consequences for the caregiver, a phenomenon known as caregiving burden. So here are some recommendations in this bill to address these challenges. The bill would require an ongoing appropriation to support dementia caregiving at each of Maryland's area agencies on aging. This will be mandated to designate a dementia, or they will be mandated to designate a dementia care navigator on their staff. The navigator's responsibilities would include support for family caregivers, including assistance with care planning and connections to support groups and education, aid in the development of dementia-friendly communities, including outreach events and professional consultations, and working to offer cognitive screenings to help identify individuals with dementia. While it can't be cured, early detection can certainly aid in treatment. The Maryland Department of Aging will be required to distribute the funding via grants to each area agency based on a formula that considers the number of people with dementia in the county. Additional funds would be reserved for a Maryland Department of Aging staff person to coordinate and oversee the work statewide. Let me just share a couple of other states, what they're doing. This proposal is modeled on Wisconsin's Dementia Care Specialist Program, which was created in 2015. The program receives $7.12 million in funding. New York allocates $20 million in funding. North Dakota, $1.3 million, and Washington, $1.5 million. I know some of you will have questions about the fiscal note, so 2 comments on that. It would go fully into effect in fiscal year 24. At that point, it's projected that there'll be about 126,000 Alzheimer's cases and 268,000 caregivers. So that's an investment of $5.96 a year per caregiver. Also, the Maryland Department of Aging budget has an additional $6 million for 2023 that must be dedicated to public information and awareness. This legislation fits that description well. In summary, we've been discussing ideas about how to help caregivers for decades. This is a solution that goes beyond a commission and actually delivers services. And finally, institutionalization is not always the best or the preferred option, but we must give caregivers the support, tools, and resources that they need to do their job. Thank you for your time and attention.
Thank you very much. First witness we have is Michael Rsas.
Hello, can you hear me?
Yes, thank you.
Yes. My name is Michael Rsas, and I want to thank the panel for inviting me to the discussion on Alzheimer's. I currently reside in St. Mary's County. My experience with the disease is personal for me. In 2015, my father was diagnosed with both Alzheimer's and dementia. I remember the nurse at the hospital said to my mom, "Your husband can no longer live at home. He will need to be placed in an assisted care facility." And we had no one to turn to. We did not know what to do. And we were thrusted in this dilemma. Not to mention the enormous cost and emotional toll it took on our family is something no family should ever have to go through. In 2017, my father passed away at age 86 to a better place. But our remaining family were left picking up the pieces of financial and emotional toll in our family. We did our best. In 2019, at the age of 58, I was employed at Lockheed Martin as an avionics electrician on the CH-53K helicopter program. I was in the prime of my life and my earnings potential. It was shortly after the recent heart attack that I had. I was experiencing issues with my memory. Despite my front row seat with my father's illness, I didn't see it. I was evaluated with a battery of cognitive testing consisting of CAT scan, MRI, and finally a PET scan. I learned this devastating diagnosis once again, and I did not know what to do. I was in a very dark place, and my doctor explained to me that I had early onset of Alzheimer's. I'm basically living with a disease that comes to kill, steal, and destroy. I've had failed treatment with neurologists, counselors, and provide that urge long-term strategies and medications to mitigate the onset of the disease. Most importantly, I attend a group of people in my age group afflicted with early onset. That's called YES, Young Early Onset Alzheimer's Support Group in Baltimore County. I will tell you that my future is uncertain and I'm pretty scared. But I will say that I can't say enough for the role of the caregivers, for they are indispensable, providing support to families who are going through this for the very first time, including support groups, testing, and long-term care. They are vital assets for families faced with this cruel disease. Please, I urge you to support Bill 7 HB 7301. Thank you, and I appreciate your time.
Thank you very much for your testimony. Larry Thomas.
Good afternoon, everyone. Can you hear me?
Yes, thank you. Go right ahead.
Wonderful. Good afternoon, and thank you so much for inviting me to provide my testimony today. My name is Larry Thomas, and I've been a resident of Maryland for over 35 years. For over 23 of those years, I've been a long-distance caregiver, providing care and support for family members who reside out of state in North Carolina, including my aunt for 9.5 years, with no family support, and now my 100-year-old mother. My aunt passed away at 95 in August 2014. Since March 2019, during the COVID pandemic, I spent the majority of my time in North Carolina caring for my mother, working remotely, and finally retiring in September 21 so that I could devote more time to her. The plight of caregiving in America is a national epidemic. The emotional, psychological, and financial toll that the stress of caregiving has had on me is unmeasurable. It is only by God's grace that I've not suffered the financial wipeout that is so typical with so many families. In November 2015, I was inspired to co-found a caregiving support ministry in my church in Maryland. The stories that are shared by members of this group are horrific. Many have suffered great financial loss, including exhausting their savings and retirement accounts, losing their homes, and going hungry to care for their loved ones. I beg your support of Bill HB 0731. Thank you very much.
Thank you so much, Mr. Thomas. And to both Mr. Thomas and Mr. Razzi, the committee truly appreciates your time and testimony on this issue. Eric Cultromero, sorry, Eric.
Not a problem. And before I get going, I just want to thank Mike and Larry. I rarely get emotional during these hearings. I've been doing this for a while, but that affected me. Eric Cultromero, Director of Government Affairs with the Alzheimer's Association here in Maryland. And I think the testimonies you've heard have encompassed the logic behind this bill. The Department of Aging and caregiving are issues that rarely get legislated. The fiscal note is a significant one, but the money is there. The Department of Aging has extra money in its budget for public awareness and information, and this is a proven solution in an area where there have not been many solutions proposed. I'm thrilled that along with Mike, along with Larry, we have Joy Schmidt, who is part of this program in Wisconsin, signed up to testify today. The only thing I would just add is about the outcomes, perhaps. There are in Wisconsin's program, in the last year of data, over 8,000 contacts with residents and referrals to service providers, over 3,900 memory screenings conducted, and over 1,903 in-person events reaching 46,153 residents with information about dementia and caregiving. Thank you for the opportunity to speak today. Thank you to the 19 co-sponsors of this legislation who recognize the importance of dementia caregiving and the toll that this takes on caregivers. And I urge a favorable report.
Thank you very much. I believe Joy Schmidt is here all the way from Wisconsin via Zoom. Ms. Schmidt.
Thank you, and thank you for letting me speak. I'm Joy Schmidt, a dementia care specialist in Dane County, Wisconsin. The DCS supports people living with Alzheimer's disease and other forms of dementia and their caregivers. We provide information and education, and we connect people to resources. We also support dementia-friendly initiatives like memory cafes and promote early detection of dementia through memory screenings. The pilot DCS program began 9 years ago. It was shown to improve the overall well-being of people living with dementia and to delay the need for nursing home care, which saved taxpayer dollars. As the pilot program was ending, citizens mobilized to support it. They shared positive experiences from working with their local DCS. Family members and caregivers from across our state came forward to fight for these positions and to support the need for knowledgeable advocates. For some who participated in memory screenings, it meant finding a treatable condition or early detection. For others, it meant getting reassurance about their memory and information about normal changes. From Joe, the last couple of years have been spent thinking and reflecting. I just want to take the time to say thank you for all your time and counsel that you gave to Sarah and me. At the time, little did I realize how far over my head things had gotten. It really became apparent how bad Sarah had gotten after she went into the nursing home. It was the most difficult and trying time of my life. I miss her every day. I have often wondered what I would have done without your guidance. Joe and Sarah had attended a memory cafe at our governor's residence, hosted by Wisconsin's First Lady, Mrs. Kathy Evers. Working with the DCS, Mrs. Evers made the governor's residence dementia-friendly, and she is now carrying this mission to other first spouses across the country. The DCS program has been invaluable to our state. It has provided people with the information they need to access resources, cope with losses caused by dementia, and remain engaged in their community. I urge a favorable report on House Bill 731, legislation modeled after our Wisconsin program. Maryland will benefit from this. Thank you.
Thank you very much. I have one more witness signed up. I believe she is not here, Margot Quinlan. Just confirming that Margot was not able to make it today, and then opening it up to questions. Do we have questions from the committee? Go ahead and raise your hand. I don't see any hands up. I did have a question that maybe is for the sponsor or for Eric. So answer it, sponsor, send it to whoever you think is best. How does this program, which does include a state level position of dementia care coordinator in the Department of Aging, interact with the bill that we just passed overwhelmingly, Delegate Sample Hughes's bill that was the staff position, the director level at the Department of Health?
Good question. I'll have Eric answer that because they are different. Eric, are you still with us? If
yep,
not.
I'm muting. Thank you, Delegate.
Okay.
Great question. And thank you again to the committee for their support of the Director of Dementia Services and Brain Health. The short answer to that is that that position was placed at the Health Department as a perch to oversee dementia services and brain health across state government. The Health Department is the best position for that perch because dementia is a chronic disease, because of the $1.23 billion we spend on Medicaid, and because of the strength of that agency in connecting with others. This legislation and the caregiving lead in the Department of Aging is in another agency because at the local level, it is the Department of Aging that coordinates caregiving services. So for the same reason, we need a director of dementia services and brain health to oversee everything statewide. It's because the work of dementia is across state agencies, and it's Aging who does this work on caregiving.
Thank you very much for that clarification. I don't see any further questions from the committee. So that will conclude the hearing on, I don't even remember the bill number. I'm sure Delegate Lewis Young knows it. House Bill 731. Thank you so much. Next up is me, which is House Bill 970, Delegate Kelly, Managed Care Organizations and Health Insurance Carriers, prior authorization for HIV post-exposure prophylaxis for victims of sexual offenses prohibition. And this bill, I will just describe it very briefly, and I hope our witnesses are here for it because they can speak to it better than I can. Delegate Carr and Delegate Cullison will remember that when we had our Montgomery County meeting with MedCai, which we do at the beginning of every session, there was a story told by a provider in Montgomery County, Dr. Irfana Ali, about an incident in her urgent care where a patient came after a sexual assault and was not able to obtain post-exposure prophylactic medication to prevent HIV infection. I think that everybody wanted to do something about this, so we did a little bit more digging with the help of MedChi and partnered with the insurance carriers to figure out what we could do to make sure that does not happen again. So just so the committee understands a little background, because we did have a bill last week from Delegate Resnick dealing with the same issue. That was to remove a sunset on a pilot program that deals with making sure that people who present at hospitals have access to this very important medication. But we found that we really need to close this loophole so that people who present at urgent cares also have access to this without prior authorization. It appears that the insurance carriers largely in our state are not having prior authorizations, but there was at least one, if not more, MCO that was requiring prior authorization. So we need this bill to make sure that we don't have prior authorization for post-exposure prophylactic medication for HIV. There is an amendment, it's a sponsor amendment. The approach we took, as I mentioned, we drafted this bill rather quickly. It was coming up against the deadline, would not have protected the privacy of sexual assault survivors, and it wouldn't have really been implementable on the insurance carrier side because it sort of made them identify folks who were survivors of sexual assault. So we're changing the language to be post-exposure. And I think with that amendment, the carriers are fine. And Lisa Jordan from MCASA is much happier too. So we definitely want that amendment. And with that, I will call my panel. I hope that Dr. Irfana Ali is here and she can tell us her story. And I will thank her because I think this is a nice, this is a bill that is an example of when our constituents talk to us about problems, sometimes we can solve them and make people's lives better. So Dr. Ali.
Thank you very much, Delegate Kelly, for allowing me to speak. So the Maryland State Medical Society and the Maryland chapter of American College of Emergency Physicians support this amendment, the House Bill 970. I'm going to speak in support of it. I'll give you a little bit of background. Post-exposure prophylaxis is an HIV prevention method that involves taking antiretroviral medications after a potential exposure to HIV. And so that's called PEP, and PEP reduces the risk of infection. And according to the federal CDC guidelines, exposure to HIV is a medical emergency because, the establishment of the infection can happen in 24 to 36 hours. So there's a very limited time in which a patient can be given. So this is, as you had already said, trying to remove the prior authorization. So in terms of what happened to my patient was that she came in, she had had a sexual assault about maybe just close to the border of the time that would be the end point where it would be efficacious. But I offered her PEP, and to my dismay, after she had left and perhaps several hours later, we received a fax that said that she needed a prior authorization. And then after filling out online, and you can imagine it's a busy place, having to do this really is disruptive, but this was such an important case because this was so urgent to this patient. Filled it out, and then it's hard to know whether the patient actually got it. Did she actually take it? Was she so discouraged that she left? It's hard to know. These sort of barriers do not need to be there for patients in this sort of situation, be it a she or a he. But these situations should not require prior authorization.
Thank you so much, Dr. Ali. Lisa Jordan.
Thank you. I'm Lisa Jordan with the Maryland Coalition Against Sexual Assault. We're here in strong support of House Bill 970. Thank you, Dr. Ali, for having the good sense to pick up the phone and call your fabulous delegate, Delegate Kelly, who is a statewide leader in our efforts to respond to sexual violence. I very much appreciate it. I was extremely dismayed to hear the story that Dr. Ali told and the experience of her survivor, and can only hope that the survivor was able to get the medication and is not now infected with HIV. The committee will recall that the bill that you heard before provides for this medication at no cost, and that project has provisions to protect privacy. It says you don't have to even say whether or not you have health insurance. And if this patient had just declined to say whether she had health insurance, she would have been able to get the medication at no cost provided by the state without any pre-authorization. But I suspect, she had a relationship with her doctor and went to the doctor that she knew. And you know what? Her doctor already knew she had health insurance. So there she was in this situation. And it's just horrifying that our system would put this barrier in such a time-sensitive drug for anyone, but much less for a rape survivor. Imagine the trauma, imagine the pressure of you have to take this in a number of hours, and then to be told that the health insurance company needs bureaucracy and paperwork and all of that. That's simply not just, and it's not good for public health. And so for those reasons, we urge a favorable report on House Bill 970.
Thank you very much, Ms. Jordan. And finally, Dana Kaufman.
Thank you very much. For the record, Dana Kaufman on behalf of MedChi and the Maryland chapter of American College of Emergency Physicians. We strongly support, you've heard the reasons, PEP medication has to be given extremely timely. And if there is any hiccup in prior authorization, it is going to result in it has the potential, I should say, to result in a very bad outcome. Doesn't seem to make sense for it to have a prior auth. So we would strongly urge a favorable report. Thank you.
Thank you so much. We have a question from Delegate Cullison.
Thank you, Madam Chair. Since this bill is directed significantly towards Medicaid operations, have you had any interactions with the Department of Health? And have you gotten any information from them?
We've heard peep from them on this. I think this, the fiscal note is clear that this is probably a good policy from a Medicaid financial perspective.
Okay, so we're all good on it. Thank you.
Absolutely. Any more questions from the committee? I don't see any questions, so I would thank you very much to the panel and especially to Dr. Ali for being here today. I know you're so busy. And that concludes the hearing on House Bill 970. Our final bill of the day, go team, we made it, is Delegate Parrott, House Bill 216, Washington County Nursing Homes and Assisted Living Programs, Essential Caregivers. And Delegate Parrott is presenting the bill and he is the only witness. Delegate Parrott.
Thank you. Is there a way that I can share the screen to show the PowerPoint?
Yes, sir. You should be able to.
Great.
When you have 1 minute left, I will use the chat function so you know.
Very good. Okay, I'm just trying to, here we go. Sorry. Do you all see it or no?
We can see it, Delegate Parrott.
Okay, great. There we go. Good, thank you. Thank you, Delegate Kelly, for letting us delay and come here because I had another bill hearing earlier. And committee, thank you for staying late. I thank you for listening to this important bill. We've all seen during the COVID epidemic that people in nursing homes were not able to have people visiting. This is a sad story that was just an article, one of many, where a person was visiting her mom and she had to talk to her through a window. And I could share, even in our local nursing home, several very, very tragic stories. I'll just share one. They told me the story of a wife who was inside. They both lived in care facility, but she had to go to the nursing home. And so the wife wasn't allowed in to see her husband. And she ended up watching him die on Zoom. It was a horrible situation, shouldn't have happened. And this bill will allow one person to be a caregiver so that one loved one could be there throughout this type of situation. They would have the same criteria as the nurses would. So the problem is social isolation is now listed as a cause or contributing factor on death certificates. This happened a lot during COVID. They were alone and they died of loneliness and the actual stress of not having their loved ones with them. You can read the next one. As a result, a lot of states have incorporated bills like this one, and they've named a few of the states. Ontario, Canada did the same thing. This House bill is modeled after a Minnesota law, and this bill is local only to Washington County. They changed the national guidelines for this in November of 21. So actually, it's a big support for residents' rights right now, but they can always change it. It's the first of the state and local government. So in good news, the Maryland Department of Health did change their guidelines so that people are allowed to visit folks in nursing homes right now. So that was a positive development, but it's it's temporary. It could be revoked, but we would like to see Washington County have guidelines for a designated essential caregiver. So one person could be an essential caregiver to one family member or close friend, and they would have to follow the same rules as the nursing home. And our nursing homes in Washington County, they support this bill. So does the county commissioners, so do the county commissioners and the Washington County delegation. And that just shows that. There are a few arguments against this bill, and from what we saw from last year. One is that HB 983 may already take care of it. That was a bill that passed last year. And it would have had the bill not been amended. Unfortunately, it was amended, and a lot of these allowing the visitations, that was stripped out of it so that it's not taken care of. This bill is needed. Also, there's an argument that essential caregivers shouldn't be a substitute for professional staff, and I fully agree. They're not a substitute. They're just there to be with the person and help them not be lonely. They're not supposed to be taking care of them. That's still a nurse's job. One other argument is that they mentioned a Minnesota case where they changed the rules to allow people to come in, and they said, well, that resulted in a spike. Well, that was really just coincidence. When we look at what happens, Maryland just changed our law. So the red line is the Maryland law coming to effect when visitors were allowed, but we were declining already. So the decline just continued straight line down. Had no effects on the COVID transmission in Maryland. So I would just ask you to please vote for House Bill 216. I think it's a good step to at least try it in Washington County to see if we can allow an essential caregiver so that folks in nursing homes will at least don't have people with them when they're going through such a hard time.
Thank you very much. It does look like we have several questions. We'll start with Delegate Belcastro.
Thank you, Chair Kelly. And Delegate Parrott, I want to thank you for your intention of wanting to help individuals that do experience loneliness in long-term care facilities. I'm a newbie, so I'm sorry if that I don't know the answer to this question. Is there precedent for us taking a county by county approach to regulations of our nursing homes and assisted living facilities that you're aware of?
Well, certainly there's precedent for local bills that would affect things differently in one county than other counties. That happens all the time. And we're just requesting this would be a local bill considered like those are.
Thank you.
Thank you.
Delegate Lewis Young.
Thank you, Madam Chair. I think you mentioned House Bill 983 that was passed last year. I remember it fairly well because it's also known as the Gloria Dates-Lewis Act. But if I recall, that did provide for a catastrophic health emergency visitation in nursing homes to be prioritized to balance both the mental and health and physical health needs. So I'm curious as to what your bill would do that bill, which was emergency legislation, doesn't cover.
Well, this bill allows a caregiver to be able to go in for one person. It doesn't have to be catastrophic. Some people are in nursing homes for a long time. So they would be allowed to go in and visit them consistently. So, and we did look at House Bill 983, and it doesn't appear to do that at all, unfortunately. And it was amended. I mean, the original intent of that bill was to do this, but they amended it out before it passed.
Go ahead, Delegate Lewis Young.
One quick follow-up, if I may. If this is Washington County only, is there a letter of delegation support?
Yes, we can get that. We've already voted on it, and so we can get that letter. Yes, good question.
Thank you.
Thank you.
Delegate Krebs.
Thank you. And I know we had this legislation last year by Delegate Young, and I appreciated it. Our family was impacted by this, and it's hard. It's one of the worst things we did during COVID. But my question to you is, you've included nursing home, assisted livings, but there's not hospice or hospitals. Were they left out on purpose? Inpatient hospice facilities and hospitals?
They were not left out on purpose. In Washington County, we do have a really good hospice center. It probably should apply to hospice as well, because you're right. Even in that center, people weren't allowed to get in.
Well, I think some people stretched it so that they could get in because it was so important, but I'm just questioning that. But thank you. I thank you for the bill, and thank you for Delegate Young's efforts on this last year. And I wish we had been able to go the whole way hindsight. Thank you.
Thank you.
All right, I don't see any more questions from the committee. Just giving you all one more second. Okay, so that is the final question and the final witness of the day. So that concludes the hearing on House Bill 216. Before we conclude the work for the committee, I just want to make two announcements. Number one, don't forget it's Thursday. There's a chairman's meeting in 15 minutes after this for the folks at that meeting. And the second is Tuesday's hearings. Normally our hearings start at 1:30. On Tuesday of next week, they're starting at 1 o'clock. We have a long day ahead of us. So don't forget, members, that we start at 1 p.m. on Tuesday. Thank you so much and enjoy the